Making sure that we are able to change grades, say 2-3 weeks from now. I don't foresee it being a problem, but we want to make sure that that could happen. Yeah, so a number of you have very small changes to your grade. A number of you, your grade goes up. Others, well, we'll see. But we will handle that. Sorry about the mess, but it's our mess now to clean up. Anyway, okay. Pathology of the aorta. So you can see we're going to talk about different kinds of aneurysms today. That's really the biggest thing we're going to talk about is the abdominal aortic aneurysm. Actually, let's go ahead and abdominal aortic aneurysm. Aneurysm, the AAA, common study for older folks. In fact, when everyone gets one, every American gets one free of charge AAA study through Medicare, Medicaid, something like that. But everyone gets this at least one free study when they turn 65, just to see, because these are, well, let's see, these are deadly because they can explode. Well, not explode like dynamite, but they can rupture, and of course that is the biggest artery in the body, so a lot of blood leaves the circulatory system really fast, so they are deadly. That's why we check for them. Okay, so unfortunately I wasn't really thinking about my image order. I kind of started drawing images down, and then I looked at my notes in the book and realized I'm going to be jumping around this page a little bit, but I am going to try to stay in line with the book for those of you who are following along. So page 67, 68, we start to talk about atherosclerosis, just like in the carotid, atherosclerosis. And, you know, that is made up of different things. We have fats or lipids, cholesterol, fibrous tissue, calcium sometimes. I'm going to write neovasculature. In other words, new vessel, blood vessel growth. Neovasculature. And what was the last thing? Complex carbs, complex carbohydrates. I was going to look that up. That's actually new for me too. But zoom in a little bit. We just have a little stretch of aorta. Perhaps this is the SMA. And yes, we can find plaque here and plaque there. That's certainly possible. But we're more likely than not to find plaque at branch points. Just like in the carotid, where we were more likely to find, not that we've seen it in lab, but we're more likely to find carotid plaque at the bifurcation of the internal and external, and also in the bulb. The plaque in the aorta is more likely to occur with these branch arteries right at the beginning of the arteries. So this is the SMA. This person may have some problems with pain when after they eat, because they go to digest food. The blood vessels in the intestines increase in size. They vasodilate. Blood should be speeding up here, but of course now the faster it goes through this stenosis, the more pressure drop. So then you're going to have someone who's literally afraid of food. Well, not literally afraid of food, but that's fear of food is one of ways that they discuss someone who has pain every time they eat. So the etiology of why atherosclerosis occurs is anywhere from unknown, UNK for unknown, to more commonly, and I think this is really what's going on, is inflammation of the vessel, specifically the tunica intima. Inflammation, I'll just say intima actually. Inflammation. So what causes those kind of inflammations? Well, smoking, and I know no one in this class does that because that is bad. Let's see, smoking. Oh, diabetes mellitus. So when you see DM, that's usually diabetes mellitus. And well, that, guys, is really related to sugar. People with diabetes can't control their blood sugar levels. Sugar is bad for the intima. So those, if we have a lot of sugar in our diet, or if we have diabetes mellitus, we are eventually doing damage to our vessels. Another reason to say no. Hypertension, HTN for hypertension. And I also want to say that hyperlipidemia is that the question that some doctors are asking, is it the cause of atherosclerosis or effect? Does atherosclerosis or inflammation causes hyperlipidemia? So is it a cause or is it the effect? Is hyperlipidemia predisposing someone to atherosclerosis, or is inflammation the effect of, how am I saying this? In other words, we're very concerned in this country about hyperlipidemia. What's your cholesterol level? What's your fat levels? All that, and causing plaque. And I'm not going to deny that perhaps there's a two-way street here with cholesterol, but plaque here is it's the prescription for inflammation. Inflammation causes the plaque. Why does the plaque occur? Because the body is trying to repair itself. And so trying to repair itself, one of the things that goes into this purposely by the body is cholesterol, lipids. And so that's why I say it could be putting the cart before the horse when we're very concerned in this country about your cholesterol levels. But if you haven't noticed, I have a bit of a soapbox about that. So I will jump off of it and keep moving on. The book jams tortuosity, and I have a tortuous aorta here. It just kind of throws the term tortuosity in a little paragraph there for no real reason, and then moves on. I will come back to tortuosity, but AAA is the next thing we're going to talk about. Now, one of the causes of AAA is atherosclerosis. Atherosclerosis weakens the wall. Let's say it weakened the wall over here on this type. It's a different type of aneurysm here. That is one of the causes of it. So, but AAA, abdominal aortic aneurysm. There are two kinds of AAA. There's two kinds of aneurysms, I should say. the real aneurysm, just plain old aneurysm. And that involves, let's see, yes, is aneurysm here. So what I've drawn here, by the way, guys, is this is a residual lumen. This whole gray area is thrombus. We don't normally see thrombus in arteries, guys, because thrombus occurs where the blood is traveling very slow. But look at just look at this picture over here. It's kind of like the bulb of the carotid. In the carotid, the blood slowed down and swirled in the bulb before moving on to the internal and external. Well, in these aneurysms, blood slows down because it has so much more room to get through. The volume flow is going to be the same before, in, and after. But with all that extra room, it doesn't have to travel as fast to create the same amount of volume flow. So thrombus does occur in these aneurysms, especially the larger they get. And I've drawn these lines in here because over time, it's like layers, it's like onion layers of thrombus. So over time you have like, or like tree rings really is probably a better answer, a better explanation. So with a true aneurysm, actually let's write that, T-R-E, true aneurysm, we have all three layers. Let's see, true aneurysm, really? Little frustrating. All right, well, while I figure this out, a true aneurysm has all three layers involved. The tunica intima, media, externa, although we don't call it externa, we call it finally, adventitia. So let's go over here, the tunica adventitia, adventitia, media, interna. All three layers are involved in a true aneurysm. Okay. The other kind of aneurysm, and your book doesn't do a really good job of saying this, and I don't know why, because actually I'm really happy with this book.
I'm sorry, Kurt, I have a question of the true aneurysm.
Yep.
Did you draw it in the way that we're going to be looking at it on the ultrasound?
Yeah, so this would be a transverse view. And so like, over here I drew a sagittal view of a different kind of aneurysm. This would be a transverse view. And this is very much what it looks like, actually. I mean, I drew red in there because it's blood, but normally it'd be anechoic unless you have color on. But just so you know, these guys over here, that's kind of our X-ray view. That's not what ultrasound's going to look like. Down here, that's more like ultrasound, ultrasound, ultrasound over here as well. These these transverse, these three in a row here are transverse views. These were more or less look like that, and then this one's a sagittal view over here. So let me draw a couple more arrows here. That last arrow didn't quite hit the mark, but you get it. There's, on this level down here, I have a adventitia, media, intima. Up here, I have a adventitia, media, and then the, I'm sorry, say that again, intima, media, and then the adventitia itself is blown out. So there's basically a tear, a hole, whatever, into two of these levels, two of these layers, and the third layer is intact. This is one form of pseudo aneurysm. That's one form of pseudoaneurysm, and I really wish they, in every book I've seen so far, they kind of a little wishy-washy on this. Doesn't involve all three layers, therefore it's a pseudoaneurysm, but this one is still contained. The other kind of pseudoaneurysm, you could see where I've drawn right in here, all three layers have been compromised. Perhaps this was actually done by a doctor's needle. And I'll actually tell you a great story. When I was a student, I might have told you this already because it happened during a carotid exam. But in fact, I do think I told you, but I'll be quick about it. It wasn't during a carotid exam. We were actually doing a biopsy on a thyroid, which, as you guys know, is right there as well, up there in the neck. And she put the guide needle in, because this wasn't just a needle, it was actually a gun. It fires a needle out and then back in. And she fired the needle out through the thyroid right into the carotid artery. And instantly, pseudoaneurysm swirling around in the neck there. It didn't go flying out of her neck, thank God. It was contained within the muscles and the fascia of the neck and the skin of the neck as well. And she was very calm about it. It looks like it was probably the 10th time she'd done it. She was so calm, but she just looked at me and says, "Oh, we have a little bit of heme involved here. And so I'm going to need you to hold it right here." I said, yes, ma'am. And I held it there for about 20 minutes, trying to stop the bleeding. And we did eventually stop the bleeding, but that was fun. But that's another kind of aneurysm where the entire wall is broken, and then there's usually some kind of limiting factor. The blood just doesn't go everywhere. And in the case of the aorta is a retroperitoneal. So the blood normally doesn't break out. It could. Well, it could, especially if a needle did this. Like a needle somehow went through the body, through the posterior aspect of the peritoneum into the aorta. Well, then, yeah, now we have a bit of a problem on our hands. Now we have blood going out and causing hemoascites or hemoperitoneum. So that is not good. Otherwise, it should be contained under the peritoneum. In fact, I noticed your book I think this might be a typo. I think it read that the most common place for this type of pseudoaneurysm, or for the blood to go in this type of pseudoaneurysm, is into the peritoneum. No, that's not true. I had to look it up because I was really surprised by that. And no, it's not true. I think she meant, or the author meant to say retroperitoneum at that point. So anyways, yes, true aneurysms, pseudoaneurysms, two kinds of pseudoaneurysms. One where at least the adventitia is still intact. Maybe the media as well, but at that point, how would you even know? But the adventitia is still intact, so the blood is still contained, or a pseudoaneurysm where the blood is literally leaking out of the artery. So hold on. So, page 2 of my notes. Oh, I actually did jump ahead. So this page 2 is my risk factors. Oh, no, this is risk factors for aneurysms. Sorry. I know what I'm talking about. Risk factors for aneurysms. Well, I didn't leave room for this. All right. Whoops, can't draw with that. I'm not gonna draw pink. That is not cool. Risk factors, once again. Smoking. Syphilis. Fortunately, I don't have any funny stories about that. And one thing your book doesn't mention, I don't know why. Connective tissue connective tissue disorders, such as the most common being Marfan syndrome. People with Marfan syndrome, they're tall, they're lanky, and that doesn't cause problems. But what does cause problems is that their connective tissue is very, very, very stretchy. And these are the people who are they're very double jointed. They could pull on their skin until it looks like it's going to tear off, but that's just because the connective tissue in their skin is so loose. Well, the problem is, of course, if your connective tissue is that loose in your major arteries with all that blood pressure in there, people with Marfan syndrome have a very high rate of aneurysms. Okay. Oh, the next thing I have written down is skinny old ladies. And skinny old lady is not going to be found in the book, but I've decided to. So a lot of times we get scripts in, prescriptions for a AAA, and I see this tiny little lady, usually a lady. I mean, obviously it could be a tiny little man too, but it's usually a tiny little lady, very thin, older. And what happens is normal lordosis, the sway in our lower back, of course, brings the aorta closer to the belly. In fact, some people, I've had students where I've actually measured like the skin line from here to here, and it's like 1 centimeter. You know, I tell them that I could take them out with just a sharpened pencil. 1 centimeter between the skin and the aorta. Whereas over here, higher in their belly or maybe their epigastrium, it's more like, even on a thin person, it's at least 5 centimeters deep. So what does that mean? Well, the doctor, in their job, they come in and they palpate and they put their fingers down here, do a little nail. That's about all I'm going to do is it's one single finger. They palpate here, and they get down to here. And this aorta, if you've ever looked at your own belly while you're relaxing, you can do it now if you want, your belly pulses every time your heart beats. Well, if the aorta is less than 1 centimeter away from this doctor's palpation, he or she is going to think, whoa, what is going on? There must be an aneurysm here pushing up against the skin because I really feel this this aorta. And invariably, it turns out there is no aneurysm. It's just simply body happiness. So that's why I say skinny old ladies, and that is a common thing to happen. The next thing I have written down is I saw the word ectasia in there, and I'm not sure you guys know that word. I can't remember if we've spoken about ectasia or ectatic. It's just two sides of the same coin there. Ectasia is a widening of a vessel or a duct, a common bile duct, a pancreatic duct, a blood vessel, a widening without really rising to the level of an aneurysm in the case of an artery. So it's just simply widening. So if this is normal aorta, normal caliber, or is ER, calibre? No, anyway, doesn't matter. I think it's ER. Normal caliber there, and then we can call this ectatic. Not rising to the level of aneurysm, but still concerning. Perhaps if someone has an ectatic aorta at 50 years of age, by the time they're 60, it's an aneurysm. I have some numbers here. Let's put them down here. Get rid of.
Can I ask you a question real quick about the ectasia?
Yeah.
When that's widening like that, it's just the whole vessel. Like, are we gonna get into like the pathology of why that's widening like that?
Yeah,
That it's widening.
Yeah, so you wouldn't use the term ectasia if it was focal. One of my arms is gone. You wouldn't use the term ectasia if it were focal. It's more of the whole thing is widened. Ectasia in an artery, it very well could just be that the person's 90 years old, and that artery is a little weak, and it's been doing its job for 90 years. It's gotten a little wide over time. Ectasia in other ducts could be a sign of some kind of backup, but in the arteries, it's usually just an older patient, but it could be a sign, well, like in Marfan syndrome for certain, could be a sign of a future problem.
And when you were doing your Doppler, like your spectral Doppler on there and stuff like that, is the blood flow still normal even though it's widened out like that? Like the blood's still flowing in the laminar layers and all that?
Yeah, it's going to be laminar. It's going to be slowed down though, because once again, the larger the vessel, let's just say it this way: it's the same volume flow rate, but if the vessel is larger, it's going to carry more volume per centimeter, so it could travel slower. But for the most part, it should be the same. About 2 centimeters is normal for an aorta in an adult. A little bit less for women, a little bit more for men. This is a middle of the road number, because we don't really call it aneurysm until it's equal to or greater than 3 centimeters or 50% increase over normal. So 50% increase over normal. If we're looking at the aorta just as it's coming through the diaphragm, and we measure it at well, we measure it at 2 centimeters. Well, no, let's just say we measure it at, well, no, at 2.5 centimeters, and whatever 50% of 2.5 would be, 0.75. So 3.2. If it's 2.5 here and 3.25 over here, that's 50% over normal. So that would be considered an aneurysm. So either of these definitions really depends on where you work. Is where we consider that normal or abnormal, or which definition you use, just 3 centimeters straight or 50% over the normal. Consider aneurysm or. Oh, and iliacs are generally 1.5. Here, I'm going to use this. These little squiggly lines mean about 1.5 centimeters is normal, or greater than, if it's greater than 50%, it's abnormal, it's an aneurysm. That makes sense?
Yes.
1.5 centimeters normal for the iliacs, about 2 centimeters normal. You know what? When we take a break, I'm gonna look at the book. As far as I'm concerned, or as far as I remember, the book only gave it's basically, there are maximums for men, maximums for women, beyond saying 3 centimeters. So I'll look that up. I feel like that could be important information. Okay. So I already mentioned that there are true aneurysms and pseudoaneurysms. Those just are involving what's involved, all 3 layers, or 1 layer, or all 3 layers broken. But the aneurysms also come into different shapes. Or come with different shapes. Okay. I'm going to start with this shape here. This is probably the most common. This is called, fusiform. A fusiform aneurysm, kind of like a diffuse type of aneurysm. It doesn't grow really fast, just kind of grows up and down and up and down the other way. We have this one here. Let me write this up here. Saccular. This saccular is more likely to be a pseudoaneurysm, at least a pseudoaneurysm where the adventitia is still intact, whereas a fusiform is more likely to be a true aneurysm. Oh, your book mentions dissecting. That means, all right, I'm gonna go in order. Let's try to keep it in order. Dissect, there's my dissecting aneurysm here. So aneurysms, you can have a dissection without an aneurysm. But if you have an aneurysm, your chance of getting a dissection increases a lot. So when we're looking at aneurysms, we're going to look for something that looks like this. This is intima layer. It has torn itself off the posterior abdominal aorta here and is now floating in the middle. And if you remember, this could be open-ended, open-ended. So when we put Doppler on, you could have red and red. If it's not open-ended, you might have red and blue or red and no flow. But I've decided to draw one that was open-ended, meaning, open-ended meaning, can't draw it in that plane. Let's just give this guy a dissection here. The blood is able to flow over and under. However, if the dissection ends like that, this flow down here, you cannot go very far before it runs into basically a wall. So it is no longer really going forward. That's, it might do a little bit of back and forth flow. So that's a dissection in long, a dissection in transverse. Oh, another great way. These could be hard to see. So one thing that we could do, which is kind of fun, I really haven't given myself a lot of room, is, oh, let's do, an M mode on a dissection. You do an M mode on a dissection, it's pretty cool because, you know how they look. You know, the blood vessel wall here, blood vessel wall here, and then in the middle, you might see drawn out over time, you see this intima waving in the breeze. And that's a great way to prove that you're not looking at an artifact. Because a lot of times, remember reverberation artifact? Reverberation artifact sometimes gets in the middle of a larger vessel and we think, oh, I see that all the time. That's nothing here. I'm just seeing the wall of the aorta, and it's been reflected back and forth a couple of times, or an extra time, and it's creating an artifact here. Well, if you ever want to prove that it's not an artifact, M mode is a great way to go. I got to remember something about measurements. What's next to my thrombus? Well, I already mentioned the thrombus. How far from renals and iliacs involved? Okay. Let me come back to here. So, okay, well, let me just get this out of the way real quick. Other locations, if you have a fusiform aneurysm, it very often involves the iliac. So we'll always double check for that. But it is possible to have isolated iliac only, and usually be bilateral, iliac only aneurysms. Or you could have renal artery aneurysms, or you could have SMA aneurysms, hepatic. Where am I? Yeah, let's just for the fun of it, we'll just create an aneurysm here on the SMA. This guy's a hepatic artery might be an aneurysm, or if you go off in the other direction, you could have an aneurysm towards the spleen. So a lot of these other arteries, these arteries up here, by the way, are called the splanchnic arteries. I don't know why they're all splanchnic, but the hepatic artery, the SMA, and splenic artery itself are all considered splanchnic arteries. So any of those can have isolated aneurysms as well. Those are a lot more rare. We find abdominal AAAs all the time. We don't find those others too often. I do have to mention, well, let's actually mention it with this. So something I did as a student No, actually, I wasn't a student anymore, but still made a. This is tortuosity. Now, you could have tortuosity, and well, you could have it up in the neck. Um, you've seen images of vessels literally doing a loop-de-loop. Tortuosity in the neck sometimes occurs with older people, and literally their neck gets shorter and their artery doesn't, so it kinks around. This could happen with or without aneurysm in the abdominal aorta. And once again, it could just be you're born that way, or it could be that you're older, you have shrunk, and your artery hasn't. So it's kind of has to kink around to do that. So this artery is it's at one. Tortuous. Oh, that's not three different words there. It's just tortuous, as in like tortured, and that's literally where the word comes from. Now, measuring this aorta, I made a mistake when I was a fairly new tech. I measured, thought I was so good, straight across like that. Well, and I measured this at probably 20 centimeters. And the radiologist called me in. He said, look, Kurt, he says, was the patient dead? I said, no. He says, well, at 20 centimeters, he probably would be. What I measured was really somewhat of the length, right? Because a true transverse measurement in this region would have been more like there, or maybe there, there, there. All of these, basically, if you take, maybe not this one, that's not perfect, that's okay. If you take the shortest distance across the vessel, then you are measuring the, in this case, the width of the aneurysm, the width of here, the width there, the width there. When I did this measurement here, this first measurement I put in, not only was I measuring the width, but I was also kind of measuring the length. In other words, I was a little bit oblique on the vessel, and so I way overestimated the size. It was a big one. There's no doubt about that. But I did overestimate the size by measuring across the length like that. So that's one thing I want to mention about measurements. The other thing we measure is a distance. Brilliant. The distance from the start of the aneurysm to the renal artery. That distance there. And the surgeons want to know about this, because when they put a stent in, or they actually do open surgery, they want to know, because an aneurysm that does not include and is at least a centimeter away from the renal arteries is a simpler process to deal with. If this aneurysm is close to or involves the renal arteries, it involves the renal arteries more like that. Now we have a situation where the renal artery is in danger of getting thrombus and throwing clots into the kidneys. Dissections are a bigger problem as well. By the way, remember, I think most everyone knows a thrombus in the leg, is a DVT, deep vein thrombosis of the leg. If it breaks off, it sends an embolism. An embolism in the venous system goes back to the lungs. Shortness of breath, you can't breathe, you might die. Thrombus created here, and thrombus, and so we'll have thrombus along the edges here very often. Of course, this is an artery. Blood flow is in that direction. An embolus breaks off, it's heading down the legs. And so one indication of that there's something going on in the arterial system, you don't necessarily know, but it could be a AAA, is suddenly the foot goes blue because a major artery to the foot has been blocked by this embolus, thromboemboli. Okay, that was a little bit of a sideways turn there, but worthwhile. Okay, 147. Let me just finish telling you about wait, don't go too fast, Kurt. Once again, I'm going not fast. Guys, if I'm going too fast, by all means stop me. Actually, I'm gonna move this over just a little bit more. When measuring the aorta, by the way, we measure in most vessels, all ducts, most vessels, this is not how it's done. In the aorta, this is how it's done. Outside to outside. So you will see a wall of the aorta. You measure outside to outside. So in an aneurysm, outside to outside. You could also measure lumen. Now lumen would be lumen only. You can measure what's left of the residual lumen. If we have the capability, we do have the capability. I mean, every machine has capability these days. We can measure an area of the lumen and compare that to the area of the entire, what would be the lumen if there weren't thrombus. So once again, measurements outside to outside, whether there's an aneurysm or whether it's normal, always outside to outside. You can measure side to side as well. But that again is going to be outside to outside. If you have an aneurysm, you should measure the lumen, the actual lumen, the residual lumen. Let's call it that. That's a little bit better. Residual lumen, you can measure just an anterior, posterior, or you can take an area measurement. And the same thing with the thrombus left over, you can measure that separately as well. Okay, so I measured. Oh gosh, I guess I am a little bit out of order with the book. Sorry. More often thoracic. Oh, so I'm a little bit out of order today, guys. I apologize. Where did that? I'll just mention dissections are more common. They're actually more common in the thoracic aorta, the aortic arch, than they are in the abdominal aorta. And these are deadly too. Whether there is a thrombus involved or not, a dissection is deadly because it's a big sheet of material flopping around inside of there. And what if it comes up and flops itself down and covers up both of your renal arteries? In other words, the sheet goes across your renal arteries. Or what if it goes across the entire aorta itself? Or perhaps it goes across the iliac arteries and suddenly you don't have blood flow in your pelvis or your legs. So the dissections themselves are quite dangerous. All right. AAA rupture. Well, actually, yeah, 150. Let's go ahead and take a break. 10 minutes after. Yeah, 10 minutes after 2. 2:10. We'll see you guys again. Ah! I am recording now. Okay. EVAR endovascular repair. We've gone through we've put this stent up into the aorta from the femoral artery. We put another one from the other side and sewed that together. We're talking about where we Doppler before, at, in the middle, probably at the bifurcation, and at the end of the graft. We always Doppler those. And you should be Dopplering all the way through, but you only need to show those images. And we're going to start talking about leaks. And these are called endoleaks. And I already mentioned type 1, where a leak occurs up superiorly at the anastomosis with the graft to the arterial wall. Type 3 is at this anastomosis between these two separate grafts where they came together and they were literally sewn together, and not necessarily sewn greatly. Type 4 goes directly through the side of the graft and leaks blood into this region. These are all hard to find. Then there is the type. Let's do this one. This is type 2. This is kind of the cool one. Now, what I've drawn is some lumbar arteries. So that's a lumbar artery, that's a lumbar artery, that's a lumbar artery. And then I drew one inferior mesenteric artery as well. So when this, grab my red back. When this graft was put in, and this aneurysm is created, and all this thrombus over here, these lumbar arteries, and these are arteries that we haven't spoken about in the past because we don't normally see them, we don't worry about them. But you can imagine the aorta has more than just a few branches. It has quite a few little branches that we don't even talk about. And these lumbar arteries, well, they go along the back, kind of along the rib cage or along the back, and they obviously feed the muscles of the back and everything. And normally blood flow is from the aorta into the lumbar arteries. But we've changed things considerably here, both naturally through this thrombus, but also through this graft that we've created. We now have these guys are being fed somewhere else. Now remember, arteries, especially in the abdomen, they don't just kind of go out and end somewhere. That's not quite how things go. They go out and they branch again, and they branch again, and they branch here. Eventually they'll come up and find a branch that came off of another artery entirely. Not necessarily the renal artery, but that's just the one I had available to me right now. Anyway, you get the idea. Branches, branches, branches. we now have a situation where the blood can flow backwards. So retrograde flow through the lumbar arteries or the inferior mesenteric artery, that is a type 2 endoleak. I haven't even written the word endoleak down. Endoleak. And so when you are looking for these, or when you are evaluating these, we are always paying attention to the possibility of an endoleak. Oh, I was on the wrong layer. Please tell me. Nope, I messed up. That's okay. How do we know endoleaks occur? Well, one, Doppler, but also you have to ask yourself a question. You look at previous numbers for the size of this aneurysm. Has it increased? Has it increased in size? If it's increasing in size, it's leaking. There's something going on. The other possibility is that you actually see fluid spaces developing, almost like little aneurysms, but really it's just blood being forced in here. So if you see fluid spaces, that's another concern. That's an endoleak, and then you put your Doppler on. A lot of these are very small, and so Dopplering is very difficult. Let me just go, 2:30 is way too early to drop off. While I'm pausing here, guys, does anyone have any questions? Tell you what. Well, there's a halfway decent example of an endoleak. You guys could all see this, right? Just tell me if you can. These are the iliac extensions of this graft. They haven't split into the iliac arteries yet. You can clearly see, though, blood flow seems to be coming into I'm sorry, I thought you guys were trying to contact me or something. You can see that this is probably a type 2. It looks like this blood is coming in from the side here, so probably a lumbar artery over here. Oh, that's my wife's computer making that noise. I'm trying to figure out, this one seems to be fairly high velocity leak. That looks like another type 2. Oh, this is the inferior mesenteric artery. right here. Because the inferior mesenteric artery is one of the, and there's really no lumbar arteries that are going to come off on the anterior here. Once again, we see the two blood flows of the iliac, but these are the iliac extensions of the graft. They're not quite into the iliac yet. So this is really still distal aorta. I'm having a hard time, just as I'm sure you are, is determining where exactly the aorta ends. But the only artery possible for this one is the IMA. So that's, I'm glad I looked at that. I'll just go through a few of these. I have no idea why. Oh my God. And I thought that was a baby's head. Interesting. This is pretty crazy looking, but they're calling this a giant abdominal aortic aneurysm with mural thrombus. It's amazing. Mural thrombus. Yeah. Could have used that term as well. Mural, as in a mural, as in a painting on a wall. So it's a wall thrombus. Great image. Looks like the residual lumen is dead, almost dead center on this patient. And you could see concentric circles going around it. Those are layers upon layers of thrombus over time. That's not real. Yeah, that's a phantom. But interestingly enough, they show, okay, correct caliper placement on the top. Notice that the caliper is on the outside of the wall. We include the wall on the aorta, whether we're measuring the aneurysm or whether we're measuring over here where there is no aneurysm. Incorrect placement down here. They're just inside the wall, so that's a mistake in measurement there. Let's see some other measurements to see what people are doing. Oh, axial ultrasound image of an outer to inner. Outer to inner question mark. All right. Well, you know when the internet proves you wrong on something, at least it appears that it may have proved me wrong on something. I'm going to have to research this. I have never heard outer to inner on a aorta, but that's probably a good sign that I should end today. All right, well, today's vascular. Vascular is the shorter class, so that's fine. I guess we're going to end early. Tomorrow, I'm going to try to make up for it and at least get us to 3 o'clock, because when we get back in classes, it's lab. So we want to get a little bit ahead of time here. So, and I'm going to do a little research on this picture right here. Let's see what that is all about. Axial. Well, in any case. All right, guys. I will see you all tomorrow unless you have any questions. Oh, maybe I'm not wrong. Anyway. Demonstrating 3 common methods to measure. Okay, well, there's wrong, and right. That's one way of looking at it.
Bye.
All right, bye-bye, guys.
Bye.
Good night, John Boy. less than 3. Distance of renal arteries, any outcome should be noted. Causes, I probably should have. They're including all. AI button. Go to the experts. Measurements are taken the greatest time running outer edge to outer edge. Thank you. Okay. Good. Well, for those of you who are still there, I was right. It is outer to outer. All right.